I'm Tamar-Mattis. Welcome to the seminar. Before I get started, I want to make an announcement so that I don't forget. I've been told that the chat room isn't working for this webinar. So people who are watching in cyberspace and have questions, you're going to need to email your questions to Jackie Omotalade, which is JOMOTALADE @berkeley.edu. That's JOMOTALADE @berkeley.edu. And then we'll be able to get all of your questions. So I'm going to start with a little bit of an introduction about myself. I'm an attorney. I actually graduated from UC Berkeley, and I teach at UC Berkeley now, so I'm really glad to be here on campus. I'm also the executive director of an organization called Advocates for Informed Consent, which is the first organization in the country doing legal advocacy on behalf of children born with intersex conditions or differences of sex development. And we're going to be talking more in a little bit about what that is. And I got involved in this work because I have a partner and also a number of close friends who were born with intersex conditions. And as I learned about some of the problems they'd faced in their lives, it became something that I felt very passionately about, and specifically about doing legal work, because nobody else had done that in the past. I'm also a parent of 2 children. My children do not have DSDs, but I feel like being a parent gives me a certain perspective. And I'm going to talk a lot today about what the role is of parents and what the role is of parents in medical decision making. And so I think it's kind of important also to say that I have that perspective as well. And the title of this talk is Legal and Ethical Issues in Medical Treatment of Children with Variations of Sex Anatomy. But the unofficial theme is my favorite Berkeley bumper sticker, don't believe everything you think. And we're going to keep coming back to that theme. The idea being, when we talk about the treatment of children who are born with atypical sex anatomy, a lot of what we run into is that common sense approaches haven't worked. The thing that people think is the right thing to do hasn't always turned out to be the right thing to do. And we're going to keep getting back to that. The focus today is going to be on legal and ethical issues with genital surgery, because that's been the most contentious area. But we're also going to address some other legal and ethical issues in medical treatment as they come up, because there are genital surgery isn't the only issue. I'm going to start with a little background on intersex and DSD. I use those 2 terms interchangeably. I know that not everybody in this audience is familiar with what exactly that means, so we're going to start with that. And then we're going to talk about specifically problems with informed consent and the informed consent process in surgical decision making. And then we're going to talk about surrogate decision making, what that is and how it works in these situations. To start with, though, I'm going to do a little basic background in variations of sex anatomy and in the kinds of things that can go differently from what most people expect when a child is born. So I call this part of the talk, Everything You Learned in Sex Ed Was Wrong. I'm going to ask you to just, take everything you think you know about sex and gender and just put it on hold for a minute and absorb a little new information. So what most of us think we know by the time we're about 4 or so, and gets confirmed as we get older, is that there are 2 kinds of people. There are 2 completely distinct kinds of people. They live in different boxes. There's no overlap there. Sometimes we refer to them as being from different planets, being like different species, right? One's from Mars, one's from Venus. And if you have this package of equipment, which always comes together, then you have a boy. And you can basically, we assume, you can look at any aspect of this person's sexual markers, and you can tell that they're a boy, and you can tell that all the rest comes with it. Similarly, if you have this package of equipment, then you're a girl. And those things, we also assume, always go together. And what those physical features lead to, we learn also, is if you have a boy, then he develops a male gender identity. He grows up to be a man, and he's attracted to women. Similarly, a lot of people have learned if you have a girl, she grows up to have a female gender identity, she grows up to be a woman, and she's attracted to men. Some of that stuff is so accepted. I mean, I talk about we learn it, we're taught this, but most of us aren't even aware of being taught this. Maybe we learned about chromosomes in high school, but this stuff down here, we just sort of take for granted, right? Now, we also know about some of this stuff. Well, it's usually the way it goes. And what a lot of people in society are beginning to realize and accept now is that the stuff down here, the stuff that isn't physical, can actually mix and match in a lot of different ways. Not everybody who's born with a penis grows up to be attracted to women. Not everybody who's born with a vagina grows up to identify as a woman. And these things can happen in different ways. So now we as a society sort of know that this stuff down below the gender identification can vary. What's also true is that these characteristics above what I've put as my gender identification can also vary in a lot of different ways. So when I talk about intersex conditions or differences of sex development, I'm actually talking about 30 different medical conditions. Can happen in a lot of different ways. Not every kind of mixing and matching is possible up here, but a lot of different things can happen. And some of them come from known medical conditions, some of them come from unknown medical conditions. But people with intersex conditions, basically, we're defining that group as people who have atypical sex characteristics. So for example, not everybody has XY or XX chromosomes. A number of other chromosome patterns are possible. Some people have an X and nothing. Some people have XXY. Some people have XXXY. Some people have some chromosome patterns in some cells and some chromosome patterns in other cells. So you can have a person that has some XX cells in their body and some XY cells, or some XX and some X0. You can also have a person who has XY chromosomes, but who develops some of these physical features over here. You can have a person who has XX chromosomes and develops some of these physical features over here. And I always tell people when I give these talks, in fact, we all learned in high school, if you're a boy, and we all know what that means, you have XY chromosomes. If you're a girl, and we all know what that means, you have XX chromosomes. In fact, if you have not had your chromosomes tested, and most of us have not, you don't know what chromosomes you have. I don't know what chromosomes I have. Most of us don't. It's true that these are the typical patterns, but they're not universal. Similarly, not everybody has either testes or ovaries, and they don't always go, as I said before, with these chromosomes up here. Sometimes a person is born with what's called ovotestes, where you have gonads that have both kinds of tissue in them. A person can also be born with what's called streak gonads, or undifferentiated gonads. The tissue isn't an ovary or a testis. That happens because in fetal development, the same tissue, very early on in fetal development, you don't have a boy or a girl, you have a ball of cells, right? And those cells grow and differentiate, and some of them turn into different organs. And the same cells either turn into testes, or they turn into ovaries, or they turn into ovotestes, or they turn into streak gonads. Sometimes a person is born with one ovary and one testis. Similarly, these physical features, the penis, the clitoris, the scrotum, the labia, grow from the same tissue in response to hormonal signals. So depending on what gonads develop, those gonads put out hormones. Depending on the body's ability to respond to the hormones, the genitals develop. And sometimes you get not something that is perhaps not clearly a penis and not clearly a clitoris, but it's hard for the doctors looking at it to identify. Maybe it's a really small penis. Maybe it's a really big clitoris. Sometimes what you get is not clearly a scrotum or clearly labia. Sometimes it's what they call scrotalized labia. Sometimes it's what they call a divided scrotum, where the scrotum hasn't closed up completely. And usually when you have those kinds of characteristics, that's what's referred to as ambiguous genitals in the medical world. And it's kids that are born with ambiguous or atypical genitals that are at the highest risk for unnecessary surgical intervention. So that's one thing we focus on. Not all people with intersex conditions or DSD have ambiguous genitals, though. For example, a person can be born with XY chromosomes, but they can have a body that doesn't respond to testosterone. So even though their body develops testes, if they don't respond to testosterone, the external features will develop as female. And so this will be a person that's born with a typically appearing female body, but she'll have XY chromosomes. She'll have testes inside her body where ovaries would usually be. And probably she'll develop a female gender identity. And those kids often aren't identified until they get much older and they don't menstruate. These organs develop from different tissue in response to hormonal signals, but again, you can get some different variations. So that's a sort of rough outline. I'm not going to go into all the specifics of all the different medical conditions, although I can when we do Q&A. But that's a rough outline of some of the different things that can happen. And I want to specifically also address the idea of ambiguous genitals, because I know for people who haven't encountered that before, it can be really hard to imagine. People often say to me, like, how can you be confused? Either you've got an innie or an outie. It's easy to tell the difference between a boy and a girl. How can there possibly be any ambiguity? So I have this great little line drawing that an academic named Alice Drager loaned me. And here's what we have. Here's a typical male body. Here we have what typical female genitals look like. And what we have in between is some of the different variations that are possible. Depending on the hormonal signals that the body gives and how the body reads those signals, you can get a variety of different sort of levels of development. And so when we're looking at something in here, that's what doctors will often refer to as ambiguous genitals. And how often does this happen? There are no really good hard scientific data, but the most common estimate is that it's about 1 in every 2,000 live births. It depends a little bit how you define intersex, how you define ambiguous. One of the most common conditions that can be considered a difference of sex development is hypospadias, and that's actually 1 in every 300 live births. Although in its milder forms, a lot of people would say it's not intersex, but those kids often have surgical intervention. So hypospadias is where the urethra, instead of opening at the tip of the penis, opens up somewhere along the midline, anywhere from just off the tip to all the way down at the base. That's a pretty common variation that happens. And even if it's just a mild variation where nobody would doubt that the child should be assigned male, it's still surgically repaired almost always. So what happens when a child is born with an intersex condition? Historically, these conditions have been handled since about the 1950s with silence and secrecy. Since the 50s, management has involved surgical alterations of genitals that are atypical for the assigned gender. And it used to involve not ever telling the child. The idea used to be that a child could develop a normal gender identity, but only if they had normal appearing genitals, and only if they never had any reason to doubt. And so it used to be that people who were born intersex were not told by their doctors, their parents were told never to tell if their parents were told the truth. Sometimes if doctors could avoid telling the parents the truth, they wouldn't tell them either. There's also a history of harmful and unethical medical experimentation on people with intersex conditions. And one of the most notable ethically problematic experiments that comes up is the John Joan experiment, which some of you may have heard about. Some people read about that in biology. Some people hear about it in their women's studies class. This was actually not an intersex case. It was a pair of twins, typical male twins, and one of them lost his penis in a circumcision accident. And a very famous sex researcher, John Money, had been working on this theory, the idea that a child could grow up with either gender identity as long as their genitals looked the way they should. And he convinced the child's parents to surgically alter his body so that his body looked female, and to tell him he was a girl and to raise him as a girl. And so it was, they called it an experiment of nature. They had these identical twins, one raised as a boy, one raised as a girl. And it was reported that this was successful. Although many, many years later, it was also reported that some of that data had been falsified, and that actually the child that had been identified as Joan had learned when he was 15 about his gender identity, had always resisted being assigned female, and transitioned back to male when he learned. And tragically, both of those boys committed suicide in the last few years, being very traumatized by what happened to them. So that's this very famous example. And the reason it's often connected to intersex is because while those children were not intersex, it was that experiment that was the basis for the future treatment of intersex children. The idea was, if this is successful, if you could take a completely typical boy and make him believe he's a girl and raise him as a girl, and he would grow up to identify as a girl, if you could do that with a typical boy, of course you could do that with an intersex child. And so the treatment was for many years based on that theory. And current treatment practices remain experimental for the most part, in the sense that we don't really have very good studies on the outcomes of treatment. So we don't really know a lot, actually. Most of the kids that have had these procedures have been lost to follow-up, and we don't know a lot about what happens to them when they get sent out into the world. What we do know is in the 1990s, intersex activists started to raise a critique, both of the surgical management and of the secrecy, as well as the practice called medical display, which is using children with intersex conditions as teaching tools. And the claims that were made by activists who were people who discovered that this had been done to them, because they usually weren't told by their doctors, the claims that they made were that genital surgery has a lot of problems. It doesn't work as well as perhaps it was intended to work. It can severely impair sexual function. The problems can include lifelong genital pain, loss of sensation, sometimes total loss of sensation, inability to orgasm, scarring, Scar tissue doesn't grow, so surgery that's done in infancy may not look as good in adulthood as it did in infancy, and also that can cause pain. Painful intercourse, incontinence, and leading to all of those problems associated with somebody's sex and the secrecy and shame that were imposed on them, leading to problems to forming intimate relationships and depression and other kinds of issues like that. And in fact, a lot of people reported that the need for multiple surgeries throughout childhood, because these weren't always done in just one surgery, and sometimes complications would require future surgeries, that the need for multiple surgeries throughout childhood, the numerous genital exams they'd have to have during childhood and also being used in medical display, a lot of people reported that these were causing emotional and psychological problems similar to those caused by sexual abuse. So while the doctors had the best of intentions in caring for these children, the children's experience may have been very different. They may not have understood what was happening to them and why, and it often got processed very much like sexual abuse. Some intersex people also felt that they were given the wrong gender assignment, and it is very difficult you can't undo these surgeries. So that was additionally hard for some people. And activist groups began to demand that intersex people be allowed to decide for themselves if they want to undertake those risks that come with surgery. And it's important to understand when we're talking about that the major request that was coming from intersex advocacy groups, starting back in the mid-90s, was that for children to have a say in surgical decision making, not necessarily to delay the initial gender assignment. So, a lot of people will say to me at these talks, well, how can you raise a child if it's not a boy or it's not a girl? Now, there are some intersex activists and some activist groups who will say you shouldn't give these children a gender, or who will say that actually the process of gender assignment is itself a kind of violence. But the major push we've been having is about surgical decision making. So it's really important to understand that you can assign a child a gender and you don't have to do anything to their body. Okay, there's nothing in the law that requires a person's genitals to be a certain shape. The gender assignment is determined by the doctor and it's put on the birth certificate and that's what's there. But genital surgery, and it can be changed. If you put the wrong gender on a birth certificate, you can change that. Genital surgery, though, is irreversible surgery that radically reshapes the body. It's also important to understand that typically there's no physiological problem that makes it necessary to do genital surgery. Now, sometimes there is. And I don't think anybody would say that if, for example, the child's born with a condition where urine can't exit the body and they will die in a matter of hours if they don't have surgery, nobody would say that that child shouldn't have surgery. There are other conditions that require surgery. What I'm talking about primarily when I'm talking about legal and ethical issues is the conditions, which are most of them, that don't require surgery for medical reasons. Obviously, there's no ethical or legal issue with doing surgery that would save a child's life or enable their body to function. It's also important to understand that there are no studies that demonstrate benefit from these surgeries. There's very few studies at all. As I said, most of these kids have been lost to follow-up, but there's no studies that demonstrate that there's any benefit from doing the surgery. And while no benefit has been demonstrated, we know that the surgeries clearly carry the risk that any surgery carries in early childhood, risk from anesthesia, infection, other things like that, as well as the risks that have been articulated by people who've experienced them. In spite of those critiques, and it's been a nearly universal outcry from the intersex adults who have spoken up. Basically, no intersex adult has spoken up in favor of surgical assignment on children. But in spite of these critiques, changing the medical standard of care has proven very difficult. So we're now over 15, almost 20 years out from the beginning of the intersex advocacy movement. And things have changed. They're changing, but they're changing very slowly. And there's a few reasons for this. First of all, standards of care are set by the medical profession. And it makes it very hard, actually, to change a standard of care. Basically, what that means from a legal perspective is if every doctor is doing something, or even if a respected minority of doctors are doing something, then it's not malpractice. It is an acceptable standard of care if doctors agree that it is. And that's one thing, there's some real benefits, there's some reasons that is the legal standard, but it also can slow change in certain ways. It means doctors are taught, for one thing, that if they do what their peers are doing, or if they do what they were taught in medical school, that they'll be safe from malpractice suit. And not only because of this, but for other reasons, the pace of change in medicine can be very slow. So in general, and there are pretty good studies about this, the average time in medicine from the publication of new knowledge to actual change in doctors' offices in the field is 10 to 15 years. It takes 10 to 15 years on average from the time when new knowledge comes out to the time when it's fully implemented in practice. It doesn't always happen that way, but it happens that way a lot. It's just this change is very slow in this field. Now, we're more than 15 years out, and change is only starting. But in the case of intersex conditions, there's even more pressure to slow the pace of change. First of all, these conditions are fairly rare. Even when I talk to audiences of all doctors, I often have to give the beginning that I gave at the beginning of this talk, because only a few specialists in some very focused fields are really, really well aware of these conditions. There's also the problem that cultural assumptions validate the old treatment model, which is why I opened this talk with don't believe everything you think. It's natural to think that if a child is born with an atypical body, that it can be fixed with surgery. It's natural to think that a child will be better off with a body that looks typical. And there's a lot of things we think about sex and gender that seem so natural and acceptable that it's hard to question them. So for example, I've had respected surgeons say to me, well, you just can't have a boy who can't write his name in the snow. You know, that you can't be a boy if you can't stand to pee. So we have these cultural assumptions that sort of validate the process that is happening now, and that makes the pace of change even more slow. Where are we now after this many years of efforts at change? Like I said, there's been some change. Initially, there was some real strong resistance in the medical field to the message of patient advocates when they first came out in the mid-90s, and they came out with some pretty strong language. Eventually, there was some acknowledgement that perhaps treatment was not ideal, and that maybe the people who were complaining about their childhood treatment might have some valid complaints. So there was some acknowledgement of the complaints and some changes to practice. However, many practitioners believe that the critics of surgery are the unlucky few. They're the few that are unhappy with what happened to them, and that the majority is happy, but they're not saying anything because they got their surgery and they went ahead and they live normal lives and they disappear. It's hard to counter that argument, except to say that nobody stood up. Do I have a question? Okay, great.
I have a question, and the question is, would you mind asking her about the necessity of dilating a child's surgically constructed vagina?
Sure, I can address that. I wonder if it'll go better at the end. Let me save that for the end, because there's a lot of specific questions about practice that I can do, but help me remember that, okay? I will get to your question. It's one of the things that has changed, though, I will say, is, actually, you know what? I will address that now, because it actually kind of fits in. As an example of one of the things that has changed, when you surgically construct a vagina, when a person is born without a vagina or with a very small one, and it's been decided that that person is going to be a girl, when you surgically construct a vagina, you have to do something to keep it open. And so they used to do this in infancy, and then the parents would have to dilate the child using a tool, you know, that would keep the vagina open regularly throughout childhood. And that was very traumatic, understandably, for children and for parents. And that was one of the kinds of complaints the people who had lived through that procedure raised. And that's one of the things that sort of sunk in. You know, at some point, people started to say, well, you know, actually, you don't really need a vagina when you're 6 months old. And even if you want one later, did I just lose sound? Okay. Even if you want one later, maybe you don't need one when you're 6 months old. And it is now the standard of care not to do vaginoplasty until the child is old enough to want it and to participate in the care that comes afterwards. Now, that doesn't mean it's never done anymore, because remember what I said, there can be multiple standards of care, but the most widely accepted standard of care is no longer to do vaginoplasty in early childhood. And so that brings me to another important change. In 2005, a new international consensus statement came out about the proper care of children with differences of sex development. And so this was an international consensus. That means it was a conference of some of the leading doctors in the world, and there actually were a couple of patient advocates at the table as well, which was considered a major victory. And the consensus statement acknowledges that the benefits of surgery are unproven, but it still recommends early surgery in many cases. So it sort of advises a more restrained approach to surgery, but still, and it recognizes that we can't tell if surgery does any good, but it also still advises surgery in many cases. There are still very few follow-up studies. The follow-up studies that have been done tend to focus on either the cosmetic appearance of the surgery or the success of the gender identity. So, you know, a lot of the studies that do exist will say, well, if we said this child should be a girl and she ended up identifying as a girl, then it was a success, without addressing the question that intersex activists have been raising, which is, but did she want that done to her body? Would she have chosen that procedure? Even if she would have chosen to be a girl, would she have chosen that procedure that was done to her? So there's very little data on sexual function, and there's basically no data at all about patient satisfaction with how they were treated. There's also basically no data on people who have avoided intervention. There have been a few intersex people who've grown up without these surgeries. And while I know a few, and I know a few who have chosen not to have surgical intervention, no one's done any really concentrated follow-up, except John Money, who I referred to earlier in this talk, whose master's thesis back in the 1950s, before they started doing these procedures regularly, was about people who had grown up with intersex bodies. And his conclusion was, they're doing fine. He was surprised to see that, you know, in the pre-surgery era, people who grew up with these kinds of atypical bodies were actually doing pretty well. Nonetheless, we moved to the model of surgical intervention. Something else that's changed is the justifications for the surgical procedures. So the original justification is what I talked about earlier, that the child could develop either gender identity if the genitals matched the gender. And as I said before, these claims were based on a falsified study, which was later debunked. And so that's no longer the rationale for surgery. So the next justification was that parents will have difficulty accepting a child without surgery. So the idea is, you know, parents, when an intersex child is born, they usually don't expect it at all. They did not know before their child was born any more than many of you knew when you walked into the room or turned on your computer today. I know some of you have some background, but I know some people don't. And it can come as a surprise to people. And so some people claimed, well, these parents won't be able to accept and love their children if genital surgery isn't done. Critics soon pointed out that that is not an ethically valid reason. We don't do surgery on a child because the parents are having emotional difficulty. Although some practitioners will still privately report thinking that this is a valid ethical reason. But it's been pretty much shot down as a publicly acceptable reason. So the next justification, and many still argue that the new surgical techniques that have developed in the last few decades are better, or that surgery turns out better if it's done in childhood because infant tissue heals better. But it's going to be, and there's a valid argument there about whether healing is better in childhood. There are people who debated on both sides who don't have any particular stake in this issue, but there's just not agreement about whether or not the outcomes are better. And we're not going to know for decades if the outcomes from modern surgical techniques are better, because we're not going to know until those kids are grown and can report on their sexual function and their satisfaction with their lives. So that one remains a big question mark. But the main current justification for continuing to do genital surgeries is it's based on the theory that while the outcomes of surgery are still unknown, so are the outcomes of raising children with atypical genitals. We don't know either way, and so we can't change current practice without evidence for that change. So that's the main justification now for doing it. There are claims about more conservative surgical practice out there. I've been working in the field now for almost 5 years, and I've tried to sort of substantiate some of those claims as best I can. Lots of people say they do less surgery, but there's really conflicting guidelines. So some doctors will say, well, now we don't do surgery on genitals that are only a little atypical. We only do them if they're really, really atypical, because it would be really bad to have really ambiguous genitals, but it's okay to have genitals that are just a little different. And other doctors will say, well, we don't do surgery on genitals that are really, really ambiguous because we can't be sure how those kids will grow up to identify, so we have to leave them alone. But if we're pretty sure, then we can go ahead and do surgery. So even with less surgery happening, it's sort of luck of the draw what surgeon do you get, whether or not an individual kid is going to get surgery. And as the public gains awareness of the existence of intersex people, and as awareness grows among clinicians and among parents of the problems with surgical intervention, we are starting to see some doctors discouraging unnecessary surgeries. We're starting to see some doctors encouraging parents to take more time making their decision, to consider their options. We see more doctors offering counseling and peer support for parents so that they can deal with that initial emotional distress. We're also beginning to hear from more parents who are resisting or questioning the recommended treatment practices. Nonetheless, the practice is still widespread, and the majority of doctors who deal with these conditions still consider elective genital surgery to be the standard of care in many situations. So it's still, even though there's sort of a little less, there's a little more questioning, the basic standard of care has not changed a lot in the last 15 or 20 years. We also still, at my organization where we're doing legal work, we still hear regularly from parents who are given inaccurate information or who are pressured to authorize surgery quickly when they don't feel ready to do that. So those practices are still going on out there, although they're far from universal. Okay, so now I want to move to talking a little bit about the specific legal and ethical problems with this treatment paradigm. And there's basically two big legal and ethical issues that are raised by doing this. One is about informed consent, about whether or not people are being properly informed when they're making these decisions. And the other is about the adequacy of parental consent, which is whether or not these are decisions that caregivers can make at all on behalf of children. So I'm going to start with informed consent because it's a little bit, from a legal perspective, it's a little bit easier to deal with. The law is really clear in terms of informed consent for care. Parents are usually the ones to offer consent when making medical decisions on behalf of a child. And if the parent is going to be the decision maker, then that person has the right to complete information. The legal standard is that the doctor must disclose all information that's material to the patient, or in this case, the parent's decision. And essentially that includes the diagnosis and prognosis, the outlook, the risks, benefits, and unknowns of the proposed treatment, some of which we've been over today. Any alternative treatments that some other doctor might recommend, and also what will happen if no treatment is done. If a doctor doesn't present material information and the parent or the patient experiences negative outcomes, then from a legal perspective, you can have a malpractice lawsuit even if the doctor's following the standard of care. Because if the patient doesn't give consent that is informed, then that consent isn't valid. So that's the pretty clear legal standard, and it's pretty clear that this standard is frequently not being followed, especially in regards to the risks of sexual impairment and the possibility of incorrect gender assignment. So I have one pretty egregious example up here. This is from the website of a very well-known medical school that does a lot of these surgeries. And I call this the error here, I call excessive provider optimism. The website says, our approach to the clitoroplasty leaves the patient with intact clitoral sensation, painless sexual arousal, a viable and sensate glans clitoris, and appropriate erectile function during sexual arousal. Now, I think a lot of people, having heard some of the critiques I outlined for you today, would read that on the website of a major medical school and say, wow, okay, maybe it was bad in the past, but now it works. It sounds pretty good. It sounds like it works. The problem is there are really no studies backing this up, okay? These are people believing what they think. They're putting out information because they think surgical techniques are better. And actually, when I put this quote up in front of medical audiences often, and one specialist said to me, well, that's a snake oil salesman. There's rogues in every field, right? Unfortunately, what I hear from parents is that this is often what parents are being told. And as I said, this is a public institution that's very well known and respected that's putting this information out here. So while a lot of parents are getting much better informed consent, much more sort of subtle information and much more recognition of all the things we still don't know, there really are some parents that are getting a lot of reassurance that isn't based in data. There's other problems with the informed consent process. Some doctors acknowledge difficulty in discussing the child's future sexuality with a parent. Sometimes the doctors acknowledge that they have that difficulty. Sometimes doctors tell me that the parents don't want to talk about it. Parents don't want to hear about their child's sexual function. And so we skip that part in the informed consent. Well, the problem is if that's the risk, then it's not informed consent if you skip talking about it. Doctors often strive to give parents a sense of confidence in the gender assignment. They believe it's very important for the parents to feel certain about the child's gender, and the parents often feel very anxious about having certainty about the child's gender. And because doctors are trying to give parents some confidence and trying to comfort them, they don't always adequately alert parents to the fact that children with intersex conditions frequently develop a different gender identity from the one that's assigned. Now, that can really vary by condition. There's some conditions where they can posit a gender assignment with a fair degree of confidence. There's some where they can posit it with more confidence than we could with a non-intersex child. There's a few conditions where it seems to be pretty universal. And there's some conditions where it's really kind of a 50-50 guess. So it really varies a lot. But even if there's a small chance that they got it wrong, like one of the most common conditions is called congenital adrenal hyperplasia, almost all of those kids grow up to identify as women. 95%, there's pretty good data on that. But that means 1 in 20 of them doesn't. 1 in 20 of them grows up to identify as a boy. And I would argue that when we talk about what kind of information is material to a parent's decision, knowing that 1 in 20 of those kids will grow up to identify as a boy is pretty important information when that parent is deciding whether or not to do feminizing genital surgery that doesn't have to be done right now. So we're not always seeing that. We also see that parents are often encouraged to consent to surgery early in the child's life with no psychological assistance to help them adjust to the idea that they have a child with an atypical body. And as I said earlier, that can be pretty stressful and traumatic for parents. And anybody who works in this field has the greatest compassion for parents who have to deal with this. Almost nobody is ready for this. And it's hard for them. And when a parent is in that state of trauma and shock, and they're grieving the loss of the perfect child they thought they were going to have, and they're adjusting to the idea of living with the imperfect child that they have, which all of us parents have to adjust to eventually, let me tell you. But some of us can get through the first few days without realizing it. When they're making that adjustment, that may not be the best time for them to be making critical decisions that don't have to be made right now. And so while this doesn't fall into the legal standard of consent, I would say from an ethical standard, informed consent is supposed to be not only that you're given the information, but that you understand it, that you can process it, and that you can weigh it. And when parents are very, very distraught, that might not be the best time. The best standards of care now recommend that the parents have psychological support at that time, and that the parents have a chance to process their feelings with psychological support before they have to make non-critical decisions. Unfortunately, that's happening almost nowhere. Everybody recognizes that psychological support is really important for those parents. The main reason I get why it's not happening is no one has figured out how to pay for it, which I guess says something about our whole system of medical care. But almost nobody is getting that support. So those are some of the problems we're seeing with informed consent. They're pretty rampant. There have been no reported lawsuits to date on this question, on the issue of failure of informed consent, although as an attorney, I think there are a lot of potential lawsuits out there. I have heard unofficially of several settlements in these cases. It seems obvious that as awareness grows and as the stigma decreases, that there are going to be more successful lawsuits in this area. And hopefully that'll change the process of informed consent. The next issue I want to talk about is a little trickier, and that's about the adequacy of parental consent. So it's trickier, but it's also a little more on point. And when I start talking about that, usually people's sort of initial gut reaction is, well, don't parents have the right to consent to treatment? Don't parents have the right to decide what happens to their children? So remember back to don't believe everything you think. And let's think a little bit more about what we all know, really, which is that parents don't have the right to make any decision for their children. Parents can't do anything they want with their child. And let's talk a little bit about how it is that parents usually have the right to make medical decisions for their child. First of all, the whole doctrine of informed consent that I was just talking about came up in recognition of the value that our society places on autonomy. So it didn't used to be that way. It didn't used to be that people had the right to informed consent in medical decisions. It used to be doctor's orders. It used to be you did what the doctor thought was best for you. And it's actually the concept of informed consent is a fairly new concept coming up from the 50s, and it's been growing and developing, and it's continuing to. But the idea is, in a society where we place a high value on autonomy, a competent person has a right to decide what happens to her own body, even if the doctor thinks it's a bad idea. If you're a competent adult, you have the right to decide what happens to your body. So when we talk about children, one thing that's now being recognized is you can't really talk about consent when you're talking about a child. Consent is an exercise of autonomy. It's something you can only do for yourself. And if you don't have the capacity to understand and make that decision, then no consent is possible. So this is a statement from the American Academy of Pediatrics. I continue to talk about informed consent because that's the language that doctors and lawyers both use. But what the AAP is suggesting is that we really need to talk about informed permission. That parents can give permission to do procedures, but that there is no consent when there's a person who can't exercise autonomy. And what we call this, and they talk about it here, we call that surrogate consent. So anytime a patient, not just with children, but anytime a patient is not capable of giving consent, we use what's called a legal fiction of surrogate consent. It's like proxy marriage, where someone stands up for the groom because the groom's not there. There's no one to give consent, so we let a surrogate give what stands in for consent. And there's certain standards in general for the idea of surrogate consent. First of all, in the general idea of surrogate consent, not just in the case of a child, but anytime you have an incompetent patient, ideally, the surrogate is supposed to try to figure out what that person would have wanted if they were able to decide for themselves. So when, for example, we think about people being in horrible car accidents and someone has to decide if you're going to keep this person alive or not, you try to decide on the basis of what that person would have wanted for themselves. And because you're trying to figure out what that individual would have wanted, for that reason, we often turn to family members who will be familiar with that person's situation and their wishes. If there's no way to tell what a person would have wanted, then the surrogate is supposed to decide in the patient's best interest. Theoretically, a surrogate is not free to decide on the basis of her own needs or preferences. So the theory of surrogate consent is you're supposed to figure out what that person would have wanted. If you can't figure that out, you're supposed to figure out what's in their best interest. If you're deciding for yourself, you don't have to decide in your best interest. You can make bad decisions. But when you're deciding for someone else, that's what you're supposed to do. That's the ethical underpinning of the idea of surrogate consent. And usually, when the patient is a child, the parent is the one who acts as the surrogate. The parent provides the permission or the surrogate consent. Why? Why is it the parent? Originally, this would have been based on the fact that under the law, the child was the property of the parents. That's no longer true, though. Parents do have the constitutional right to care and control of the child. So that's one reason that the parents are most often chosen to give surrogate consent, is because the parents have the right to raise the child and to make decisions for the child. This right is not absolute, however, and it can be outweighed by conflicting rights of the child. And parents are supposed to be acting in the child's best interest. Again, parents can't do whatever they want with their child, even if their intentions are good. So in the medical, we limit parental decisions in a number of areas. For example, we don't let parents pull their children out of school and provide them with no education. We don't let parents abuse their children. In the medical context, even caring parents sometimes have their rights to decide limited. And the most common situations are these. When a parental decision is going to result in irremediable harm to life or limb. So the most common example of that is there are some people who have a religious belief that you shouldn't accept blood transfusions. And one is Jehovah's Witnesses. If a Jehovah's Witness who's devout and who follows this teaching is in the emergency room and they're going to die from loss of blood, often they will choose to die rather than to accept a blood transfusion because it goes against their religious beliefs. And we have the right to do that in this society. We do not have the right to make that decision for our children. So that's a common example of when parental decision making, even though the parent's a good parent and is acting on good intentions, it will be overridden because the decision is going to result in harm to the child. Another place where we limit parental decision making is when there's a parental conflict of interest. And the most common example of this is the case of organ donation. So a parent typically can't consent for a child to be an organ donor. And the reason for that is we would almost never consider a child as an organ donor unless there was some other close relative that needed the organ and there was no one else who could give it. So a parent who's offering consent for their child to be an organ donor is typically going to be in the situation where one child has, say, a kidney, and another child needs it and perhaps will die without it. And so that parent has a conflict of interest. They can't decide just solely focusing on the best interest of the healthy child. And so those decisions are not made by parents alone. And the final example of the kinds of cases where we limit parental decision-making is where the child's fundamental rights are at stake. And this is particularly clear in the case of sterilization. Reproductive freedom is a fundamental right, and parents don't have the authority to consent to elective sterilization of their children. A parent can control their child's exercise of many of their reproductive rights in childhood, but they can't have them permanently sterilized. And the law in this area developed mostly around the practice of sterilizing developmentally disabled children, which was a historical practice. It actually used to be mandated by law in California. And it was often a result of caregivers, doctors, and parents' best intentions. But in spite of their best intentions, the practice was abused, and it was found to violate these children's fundamental rights. And so now, parents can't consent to that kind of sterilization without also having court approval of their decision to make sure it's in the child's best interest. We also effectively limit parental decision-making in a number of other areas by expanding minors' rights to consent to confidential medical care in some situations. So things like abortion, birth control, psychological services, drug counseling. We don't actually say parents can't make those decisions, but we let minors make those decisions. And I think what that reflects is a growing awareness in society that especially in certain sensitive areas, and maybe especially in areas of sexuality, parents aren't always the ones that are best positioned to make those decisions. And I think that's a sort of a growing awareness that we're seeing in society now. Where the question of best interest is open to interpretation, though, courts generally are going to support the parent's right to determine what's in the child's best interest, even if the parents have an unusual point of view. So parents can make unusual decisions for their children as long as they don't fall afoul of some of these really strong standards. So another way of looking at parental consent is that parents don't have the right to do whatever they want with their child. The child is not property. But parents do have the right to serve as the surrogate, usually, or to determine what is in the child's best interest. They have the right to be the one who figures out the best interest. Another way of looking at it is that it's usually in the child's best interest to have the parents be the decision makers. So this is another reason we give parents this important position, is they're usually the ones that understand the child best and understand the child's social situation and everything else that's going on, and that care about the child and want to make the decision, are well positioned to make the decision for that reason. And that's balanced. Because ultimately, children are people. They're not property. They're not sub-people. Under the law, children have constitutional rights. This is something I have to clarify even to my law students sometimes, but the Supreme Court has recognized this. And legally, parental rights are weak when they intrude on the child's fundamental rights and well-being. So parents have a lot of rights, but once we start getting into the area of the child's fundamental rights, those can be balanced out. And from the standpoint of medical ethics, the child is the patient, and the doctor has a duty to the patient independent of the parental desires. So this is another quote from the American Academy of Pediatrics, recognizing that while parents do have the right often to determine the best interest, parents don't have a unilateral right to decide anything they want. And that there is a responsibility to ensure the best interest of the child as well. So then, the reason for this long survey of how we do surrogate decision-making is because, to get it back to the issue of genital surgery and differences of sex development, the key question is really not, don't parents have the right to decide? The key question is this the kind of decision that we allow parents to make? And so I'm going to review some of that. I'm going to touch on a few facts, too, before we do. So in thinking about, is this the kind of decision that we let parents make? It's, first of all, I want to remind people, we're not talking about surgery that's necessary for physical health. And surgery is not, whether or not you consider gender assignment to be necessary, the surgery is not necessary for gender assignment. It's an irreversible surgery that has significant risks. And those risks, and it may include sterilization. So in some cases, still, children born with intersex conditions are sterilized. The parents are often encouraged to consent to surgery early in the child's life with no psychological assistance to help them adjust to the idea of having a child with an atypical body. There have been few studies, and there's no significant evidence that genital surgery improves these children's lives. And yet, many, many intersex people have stepped forward to say that they were very much harmed by these procedures, that they wish they had not been done, and that they wish that they were allowed to make their own choice. On the other hand, some people will point out that growing up with atypical genitals may cause psychological harm as well. A lot of people are very concerned about the stigma that the child will suffer if they have to grow up to the age where they can help decide for themselves. And some people are concerned that it might interfere with gender identity development, that children will be confused about their gender if their genitals aren't typical. Now again, that's a fear that doesn't have a lot of evidence, but it's a concern that some people have. And the question's never been answered in a US court of whether or not this decision is one that falls under parental competence. So what I want to do is take a second and look at how it fits in other kinds of decisions where we normally limit parental authority. There is a pretty strong legal argument that this procedure, the choice to do elective genital surgery on a child, might go beyond the bounds of normal parental authority. Oops. So first of all, there's the risk of permanent harm. That's obvious, right? We talked about the kinds of complications that might come from this surgery and that they're irreversible. Arguably, that might go either way, because some people would say, well, there's a risk of permanent harm in the psychological trauma the child might suffer if surgery isn't done. I would argue there's a parental conflict of interest here. And by that, I do not mean that parents don't care about their children, because obviously parents of children with intersex conditions care as much as any other parents care about their children. However, as a lot of doctors have recognized, a lot of parents have a really hard time imagining their children as future sexual beings. I know I have a hard time with that. You just don't want to think about your kids that way, no matter how comfortable you are talking about sex and sexuality. And it may be, when I talk about a conflict of interest, it may be easier for a parent to respond to their fear of the child suffering teasing in childhood and other things like that than to contemplate the child's future sexual function and weigh those things. Which is worse, getting teased in childhood, growing up to have these problems with sexual function? That's hard to weigh for anybody. I think it might be especially hard to weigh for a parent. I know, when I think about someone pushing my kid down on the playground, I want to get that kid. Like, the tiger rage rises up in me as a mother when I think about somebody doing anything to my kid. Do I want to think about, what that kid's going to do when they're grown up? No, I don't. So that's a hard kind of balancing for parents to do, and that's what I mean when I talk about conflict of interest. There is also evidence that some parents' motivations for consenting to surgery include fear of homosexuality and transsexuality. And in fact, we know that some providers will offer implicit or explicit assurance that the child will not grow up to be gay if they have these surgical procedures. It used to be part of the standard of care. It's not any longer, but still a lot of people believe it, and a lot of people offer it as evidence. And we know that providers have explained the need for surgery by citing the parent's discomfort with the child's ambiguous genitals. So that in itself, I think, shows evidence of a conflict of interest. If the surgery is necessary because the parent is so uncomfortable with the child's body, then the parent is having a conflict of interest and may not be well prepared in that moment to make that decision. We also talked about a societal history of abuse and the issue of fundamental rights being at stake. And this is where the question gets a little bit interesting. Certainly there's a history of unethical medical practice here. I'm not saying that all medical practice as it's done now is unethical, but there is certainly a history dating back to the Joan-John experiments at least. And there's a long social history of forced conformity to sex and gender norms for everybody, not just for people with differences of sex development. As I mentioned before, there's often sterilization involved in these cases, and where there's a sterilization, I think it's pretty clear that the law requires something beyond parental consent, some kind of court approval. Nonetheless, that's not being practiced anywhere in the country as far as I can tell. So there's pretty clear law that seems to not be being followed where there's a sterilization involved. So when a child is being sterilized, there's a fundamental right at stake. Mostly, though, the children that are having these surgeries are not being sterilized. Either they're not fertile in the first place, or they are fertile and that fertility is being preserved. And so that raises some other questions, like, is a person's sexual expression a fundamental right? Do parents have the right to make irreversible decisions about how their child's bodies can function sexually when they're an adult? There's also questions about bodily integrity. Again, about parents making decisions about how their child's genitals will be shaped. That's pretty personal, even in the context of a family. That's a pretty personal place to be making decisions. Do parents have a right to surgically enforce a gender assignment, even if it may turn out to be wrong? And I think another question that's worth raising in there is whether it matters that intersex adults have come out so strongly against infant genitoplasty. So there are many other kinds of procedures that parents choose in childhood, some of which are even elective. although usually they have some functional value. But if we look at situations like children who are born with a cleft lip, or children who are born with maybe very mild clubfoot, parents make decisions about correcting those conditions. But what we don't have is we don't have a body of people who've stood up and said those decisions were wrong and I regret them. And so while intersex adults don't have a formal role in making decisions for current intersex children, unless they're related, there's still, I think, an important ethical question of do we need to listen to this patient population when we're making decisions about treatment? Yeah.
There's a question about that and its relationship to intersex adults. And if they wanted to seek some sort of, excuse me, legal remedy, who would they go after? And would the statute of limitations already be run? Would they go after their parents? Would they go after the doctors? Who could they seek, I guess, quote unquote, justice from?
That's a great question, and that's how I got started in this field. The information, the recommendations that have been given to intersex adults who've asked this question is that usually the statute of limitations has run. Usually the doctors were following the standard of care at the time, and by the time most intersex adults figure out that they were born with this condition, because remember, many of them were lied to, and process the emotions they have then about it, statute of limitations for medical torts is between 1 and 3 years in most states. Some places it runs a little longer. But a lot of people, the statute has run and there is nobody to sue. We are hearing more and more from parents who feel that they were not informed very shortly after the fact and who regret the decisions they've made very shortly after the fact. And like I said, I've heard of some settlements in those cases. There's other ways the statute of limitations can be postponed. So it's not sort of hard and fast. It really depends on the state and the state law. So sometimes when a decision's made for someone in childhood, the statute of limitations might not start running until adulthood. As for who they could sue, it sort of depends on the cause of action. Certainly, doctors are taking on some risk of liability with doing these surgeries. They're taking on a greater risk if it's a sterilization, and they're taking on a much greater risk if the informed consent is not adequate. So we see different levels of risk. And yeah, in the cases about sterilization of developmentally disabled kids, parents ended up getting sued as well. So again, I know that these parents make these decisions with the best of intentions, and I also have known parents who have very much regretted those decisions when their child grew up and questioned them. And that's tragic. That's really hard for those parents. And yes, some of them could also face lawsuits, and that would be even more tragic. And that's a great transition because I was getting ready to close up, and then I'll take a bunch of questions. I'm just going to skip a few things. Looking to the future, the discussion about intersex children, I think, has exposed weaknesses in dealing with our process of medical decision-making on behalf of children generally. Our system of parental consent developed in a context where medical care was primarily concerned with curing disease and preserving life. And surgical procedures were so dangerous that we didn't used to really consider surgical procedures pretty much unless life was at stake. And now we're in a new world. And as we're facing a brave new world of medical treatment that is more designed to improve people's lives than it is designed, or enhance their bodies, or enhance their minds, than it is designed to save their lives or preserve health, sometimes in very radical ways, we may need to re-examine how we're balancing the risks and benefits of those treatments when they're being offered to people who are too young to decide for themselves. So in a way, the intersex movement, I think, might be a canary in the coal mine about what's coming next in terms of medical procedures for children and how are we going to make those decisions. And I think we can consider that in that context as well. I have my references here. And if people are interested in following up with us later, there's our contact information. But I'm just going to take questions now for the rest of the time.
So you're talking about the legal ramifications of actually doing surgery. What about the legal ramifications of not doing surgery, such as if a patient has dysgenetic gonads and they're not removed and they turn cancerous? What would happen in that respect? What would the legal recourse be for the parent or for the patient? That's
a great question. So when I covered the standards of informed consent, part of what I said is you always have to cover alternative treatments and non-treatment. So no, I don't think a doctor could just not do these procedures without letting parents know of the different options that are out there. And when you talk about dysgenetic gonads, so remember I talked early on about gonads could develop in all different ways, and in some kinds of conditions, there's a very high risk of cancer. So there we're talking about surgery that might be necessary to preserve life. So obviously, a doctor would be deficient, would be falling short of the standard of care if there was a very high risk of cancer. They didn't advise the parents of that. It's also true that the risk can really vary. So we have conditions where there's maybe a 5% risk of cancer. And we have conditions where there's a much higher risk of cancer. And so we've often heard from parents that aren't being informed about the subtleties of that. Are we talking about doing a surgery because this child is really likely to die of cancer soon? Are we talking about doing a surgery because this child might have a slightly elevated risk over most people? And so this, again, is an area where informed consent is really, really important. But obviously, where there's an important medical reason to do a procedure, it should certainly be offered.
Happening globally and internationally as far as intersex children?
That's a great question, too. Everywhere where there is Western medical care, the standard of care I've described is pretty much the standard of care. And in fact, even where there isn't advanced Western medical care, there are a lot of doctors who will go out into the field in developing countries and provide these procedures. There is also a growing intersex advocacy movement really around the world. A number of African countries now have intersex advocacy groups. There's one in New Zealand, there's one in Germany, there's quite a bit in England. So there's starting to be more sort of around the world. The standard of care is really pretty similar, though. There are some countries where medical care is difficult enough to obtain that often there's not diagnosis, or often there isn't an option for surgical intervention. And people fare in varying ways. You know, before we had these surgical procedures available, there were cultural ways of absorbing people who were born with differences of sex development. There have always been children like this. Sometimes those are stigmatized positions that are difficult to hold, and that's still true in many parts of the world today.
I had a couple of questions. The first is if you could talk a little bit more about what the medical standard was or what the approach was before the 1950s when these surgeries came about and how they did gender assignment at that time and how the parents were counseled. And then I'm also just wondering if there's any statistics, which there may not be, just about the sort of number of genitoplasties being performed each year in the United States or elsewhere, just to get a sense of you've talked about the number of live births, but just to know about the surgeries.
Right. Okay, I'll start with the last one because it's the easiest. The number of live births, the best estimate, as I said, is 1 in 2,000, and I think that estimate is children who are likely to have some kind of surgical intervention. So that, I think it's 4 million births a year in the US, so that would put us about 2,000 intersex births a year. But it is really rough. Nobody's tracking these statistics. Nobody really knows. In terms of what was done before the 1950s, there's a great book by an academic named Alice Drager called Hermaphrodites and the Medical Invention of Sex that covers this whole history, because it's varied throughout history and it's varied throughout cultures, obviously. So there's a lot of different answers to that question. At one time, the legal standard, and this is in the very old common law of England, they talked about the sex which prevaileth. So basically, they could only look at the person's body on the outside, you know, and there was no safe way to do surgery, so they would just look at the child's genitals and make the best guess, and whichever they looked more like to whoever was doing it. In some common law countries, at some points in history, people who were born intersex were allowed to choose to reassign their sex when they turned 18. So it's like you get one shot at changing if you're born with an intersex condition. Later on, when surgery was possible, they would look at gonads, and they would do sex assignment on the basis of gonads. Now, one of the questions I often get is, can't they just look at a person's chromosomes and figure out what they are? So we have this interesting thing where, as medical technology has developed, we've sort of focused on more and more obscure and invisible aspects of anatomy to try to pin the sex down, right? Well, if we can't tell by looking at the genitals, now we can go inside the body and look at the gonads. And if that doesn't give us enough information, we can go deep inside the body and look at the chromosomes. And what I say to people about that is, you know, I think a lot of people now think of chromosomes as this irreversible, sort of absolute marker of sex. Putting aside all the people who don't even have typical chromosome patterns, chromosomes are like a blueprint, right? That's how we learn about it in high school biology. I never went much beyond that, but chromosomes are a blueprint. So if you have a blueprint for a house, And what you end up with is a castle. The castle's not really a house, right? It just means the typical blueprint, like things didn't work out on the path of development. So where we are now is there aren't really good answers, and the best standard of care is to look at what the child's gender identity will be. And that may be, in many ways, where we started. But we have gone through many other phases of sort of trying to figure out how to assign children. Obviously, it couldn't be kept a secret in the era before surgery. So if parents had an atypical child, they would know they had an atypical child. It's also true, one of the most common conditions, congenital adrenal hyperplasia, is without modern medical intervention is fatal in many cases. So a lot of those kids died. Now, that doesn't mean genital surgery is necessary. Hormonal intervention is necessary to keep those kids alive. But so a lot of them died in the past.
There's a question about just the language, intersex, variation of sex anatomy. What is the proper language to use when talking about this?
Another great question. There's a great place on our website addressing that. So if you go to aiclegal.org, you can see my whole talk about that. Unfortunately, there isn't really good agreed on language right now, and that's why you hear me varying my language between intersex and difference of sex development. In the title of the talk, I called it Variations of Sex Anatomy. Those are all accurate words, and there's a lot of dispute right now. Intersex used to be the standard medical term, which replaced the older pejorative term hermaphrodite. More recently, with the new standard of care, the medical world has started adopting actually the name disorders of sex development. And a lot of intersex activists have objected to that. A lot of them prefer intersex or prefer something more benign like differences of sex development. A lot of other people really prefer it, and there hasn't been a real consensus in the community about it. So we're sort of in this place of flux that a lot of communities go through.
Thank you. The next question is, what job or volunteer opportunities or organization referrals would you suggest to someone who works in health education, not law, but wants to work in DSD advocacy, awareness, and education?
Another great question. I have occasionally at AIC taken interns who are not law students, but who are advanced level public health or medical students. There aren't a lot of really good places out there, honestly. There are a few hospitals and academic teams that are running specialty treatment teams, and some of those will take interns, if you can find the right person to attach to. So I mean, ultimately, I'd have to say anyone who's interested can call me, and I'll give the best referral I can. But there aren't a lot of opportunities, and we desperately, desperately need people specifically in mental health focusing on this issue, and I think public health as well.
The next question is, has there been any action against Johns Hopkins? There's an allegation here that they fabricated data in the publication of Gender Identity and Gender Assignment, and it's from a physician who says many of us relied heavily on the advice of Hopkins researchers in our counseling and treatment of intersex individuals.
That's a great question, and as far as I know, there's not exactly a cause of action for giving out bad information in a general way. When a doctor advises a specific patient about what to do, they have a responsibility. Publishing bad medical data might be a professional error. It might lead to professional censor, but it's not necessarily illegal. And I think a lot of people would, there's a lot to sift through there about what responsibility is Johns Hopkins' responsibility and what responsibility is John Money's. Academics have a lot of freedom, and schools try not to control that too much. At the same time, it seems like there was a lot going on at Hopkins that a lot of people feel is really questionable. And I think Hopkins has done a lot to
Give us a little bit more background of us who don't know about the John Money.
Okay. I'm going to actually refer people who don't know a lot about that to this great book called As Nature Made Him, which is the story of the John Joan case and covers a lot of the really questionable stuff. Because honestly, I'm not really expert in the history at Hopkins. But there's been some great investigative reporting by the guy that did that book, and it covers some really interesting stuff, and it addresses sort of what was John Money's responsibility and what was the hospital's responsibility. There is, however, a growing movement, which includes a lot of medical professionals, about looking at, even if legal action isn't possible or appropriate, at whether apology might be. And I think that's a really interesting question. I think in many, if not most of these cases, everybody was doing the best thing they could. And yet there were some really tragic consequences. And perhaps sometimes people were doing the best they could, but they were acting on some assumptions that in hindsight weren't the best assumptions. And I think that really raises the question of whether an apology to the community as a whole is relevant. And that's something AIC has been working on. And as I said, there's been some interest in the medical community in looking at that too.
And there's another question. What other resources are out there for parents of intersex children?
There are a few specialty centers of care, and definitely it's advised that people try to go to a specialty center if they can at all. There are a number of support groups. Most of the support groups focus on adults with intersex conditions, but there is a great parents group affiliated with, there's an organization called the Androgen Insensitivity Syndrome Society, Androgen Insensitivity Syndrome Support Group. And they have an affiliated parents group that's not just for people with androgen insensitivity, but for parents of any child with a DSD. And their website is online. I think it's aissg-usa.org. Oh, and there is a new support group for parents. Thank you. There's a new support group for parents starting at UCSF tonight at 6 o'clock that AIC has been involved in helping to start, and also the Androgen Insensitivity Support Group is helping to start. And this is, as far as I know, the first real peer-run parental support group. There are a few hospitals that run parent support groups that are hospital-run, and we're doing this in collaboration with UCSF, but this is the first one, as far as I know, that's involved outside advocacy groups as well.
There's kind of, I guess, a follow-up question to that, I guess, your answer to that question. And it is, if a parent chooses not to have the surgery for their infant child, when should they let their now adult, or not adult, but teenage, adolescent child make that decision? Should they wait till they're 18? Should this be a discussion that can happen at 13 or 14?
Mm-hmm. You know, that's a really common question. We have this sort of assumption in society that that's the question. Either you do it in infancy or you have to wait till the age of consent, which is typically 18. In fact, in medicine, there's a real idea that children possess a growing autonomy, and that they should be allowed to take increasing responsibility for their medical decisions as they grow and as they become more competent. And it's generally sort of understood among ethicists and child psychologists that around 14 or 15, children can make really good medical decisions for themselves. And certainly, you have more to go on. Even if the parent is helping make the decision, you have more to go on at an earlier age. So I think it's hard to tell what's the best age to make these decisions, because nobody's been letting the children do it. But what we do know is that as the child grows, you will get more information. As the child grows, she will have more and more autonomy and ability to participate in decisions. You know, and it gives the child to participate as much as possible in making the best decision that's possible. And it's not necessary, if you don't do surgery in childhood, it's not necessary to wait until adulthood, if that seems like the right thing to do. Any more questions? Okay, well then I get to put in a little pitch for AIC's work as well. We do take law student interns, and I do still have a few openings this summer, so if there's any law students out there in cyberspace, feel free to hop on our website. We also have a great amount of information on our website addressing a lot of the questions people have been raising today, and we have some great resources for parents, like a Know Your Rights guide and a guide on how to protect your children's privacy. We're starting also to develop resources for adolescents and youth. So I'd encourage people, if you're interested in this more, to stop by our website and have a look. And we have a mailing list up front for people who are here today. If you want to sign up on our website, if you want to sign up here, you can also sign up on our website. Was there another question?
There is another question, and it looks like it's from a parent of an intersex child. Mm-hmm. And she said that you spoke briefly on the, I guess, the exhibition of children, and mm-hmm. she's just noting that there's a lot of instances where physicians want their residents to come and see her child, et cetera, and how to deal with that.
That's a very important issue. And so one of the things a lot of adults have complained about is this practice of medical display, which as children they experienced as very humiliating and shaming. It's natural for doctors to see an unusual case and to want to learn more. And many hospitals where they have centers of care are teaching hospitals, and doctors have to learn. However, it's the parent's job to protect the child. And the child has a right to protection that outweighs the need of others to learn. And so most of the parents groups really encourage parents to try to limit the number of exams, to really ask at every exam, is this exam necessary? Why is it necessary? Who needs to be here? And if they want to let learning happen, well, there's two ways of looking at that. Some parents groups suggest that you can let the child be examined once a year and let one resident come in and no more, rather than having a whole room full of residents, which is what some people report, if the child's comfortable with that. In medical ethics, it's pretty well accepted that the child should be able to decline if it's not for medical treatment. If it's for teaching purposes or experimental purposes, the child has the right to decline. So that's something that I think parents and doctors need to be really sensitive to. And a lot of the medical students I've trained have offered a very valuable insight, I think, that yes, doctors have to learn, but it might be more important in this case to learn sensitivity to the patient's wishes than to learn what atypical genitals look like. There are photographs out there in medical textbooks that can show you what atypical genitals look like. But learning how to be sensitive to these children at this very vulnerable moment might be the more important lesson. And yes, I encourage parents to be very cautious about genital exams and to make sure that when it's happening, it's in their child's best interest. Any more?
That's it online, I think.
Okay, well, thank you all for coming out, and feel free to stop by our website